Hello everyone. In this part, let's study something about membranous nephropathy. Membranous nephropathy is one most common pattern of idiopathic nephrotic syndrome. It also may be associated with infections like syphilis and hepatitis B and C, systemic lupus erythematosus, medications like gold salts, NSAIDs, and certain tumors, solid tumors, and lymphomas. In most patients with idiopathic membranous nephropathy, the antigen in the immune deposits is the M-type phospholipase A2 receptor, which is present in podocytes. Circulating antibodies combine with this antigen to form in situ immune complexes on the epithelial side of the basement membrane, thereby leading to proteinuria. Membranous nephropathy typically manifests with proteinuria and edema. Hypertension and microhematuria are not infrequent, but renal function and GFR are usually preserved at presentation, despite the finding of complement in the glomerular immune deposits. Serum complement levels are normal. Membranous nephropathy is the most common pattern of the nephrotic syndrome to be associated with a hypercoagulable state and renal vein thrombosis. The presence of sudden frank pain, deterioration of renal function, and the symptoms of pulmonary disease in a patient with membranous nephropathy should prompt an investigation for renal vein thrombosis and pulmonary embolism. On light microscopy, the glomerular capillary loops often appear rigid or thickened, but there is no cellular proliferation. Silver stain of idiopathic membranous nephropathy showing spike formation along the outer aspect of the glomerular basement membrane, corresponding to projections of the basement membrane between the epimembranous deposits. On ultrastructural examination, there are numerous closely opposed epimembranous electron dense deposits separated by basement membrane spikes. The presence of circulating antibodies to the M-type phospholipase A2 receptor are highly sensitive and specific for idiopathic membranous nephropathy. Confirming the diagnosis of membranous nephropathy in patients with a comfortable clinical presentation is pivotal in guiding management and treatment decisions. A kidney biopsy usually is considered the gold standard for the diagnosis of glomerular diseases. However, for membranous nephropathy, the antibodies against the PLA2 receptor is a biomarker that can establish the diagnosis of membranous nephropathy with high accuracy and without the associated risks of a biopsy. A kidney biopsy should be done for purposes other than establishing a diagnosis of membranous nephropathy in PLA2 receptor positive patients. There are currently insufficient data to support the use of THS-DTA antibody as a diagnostic biomarker for membranous nephropathy. All patients with primary membranous nephropathy and proteinuria should receive optimal supportive care. Immunosuppressive therapy should be rejected to patients considered at risk for progressive kidney injury. Immunosuppressive therapy is not required in patients with membranous nephropathy. Proteinuria is less than 3.5 grams per day, and estimate GFR more than 60 milliliter per minute per 1.73 square meter. The combination of cyclophosphamide or cyclosporine plus prednisone is more likely to induce remission of nephrotic syndrome compared with placebo or prednisone alone. Success with tacrolimus has been similar to that with cyclosporine. Success with tacrolimus has been similar to that with cyclosporine. Patients with membranous nephropathy are at increased risk for developing renal vein thrombosis, especially when their serum albumin levels decline. A risk-benefit approach to this problem is recommended. However, no clear guidelines exist on when to start anticoagulation. Other agents used successfully in uncontrolled or small controlled trials in membranous nephropathy include cyclophenolate mofetil, adrenocorticotropic hormone, and the monoclonal anti-CD20 antibody, rituximab. In one report, 2/3 of 100 consecutive patients treated with rituximab achieved complete or partial remission, with a median time to remission of 7.1 months. The timing of treatment start, type of drug, and the duration of therapy is dependent on risk estimates, patient's characteristics, patient and physician preferences, reimbursement policies, and societal perspective, like cost and drug availability. In most large series, renal survival is more than 75% at 10 years. In general, older patients, males, and those with heavy persistent proteinuria are most likely to progress to renal failure and hence to benefit from therapy. Okay, that's all. Thanks.